Right, now we have three speakers for you, Dr. Miranda van Hooff, Dr. Ellie Lawrence-Wood, and Dr. Galina Garagonova. I'll tell you something about them all. Firstly, Dr. van Hooff, BA with honours, PhD, is the Director of Research at the Centre for Traumatic Stress Studies, University of Adelaide. She was Chief Investigator of the Transition and Wellbeing Research Program. This is Australia's most comprehensive study examining the impact of contemporary military service on the mental, physical, and social health of serving and ex-serving ADF personnel and their families. In 2014, she conducted the South Australian Metropolitan Fire Service research examining the resilience, health and well-being of firefighters. Dr. van Hooff is joining the Road Home team as the newly appointed Scientific Director of the Australian Centre of Excellence for Post-Traumatic Stress to build on her passion for collaboration in research, knowledge and innovation care.
Ellie, Galina and I today in this session will be talking to you about combat, transition, first responders and families. So I've had the wonderful opportunity to work with these two ladies now for a number of years. I'll be starting really looking at providing a bit of an overview of some of the research that's been conducted, sort of the broad studies, and then Ellie will move into impact to combat and Galina will move into the family side of things. The first program that I'll be talking about today is the Military Health Outcomes Program of Research. So this was conducted in 2010 and between 2010 and 2012 in collaboration with the Department of Defence and combined data from 3 cohorts of Australian Defence Force personnel. Regular, reservist and ex-serving ADF personnel who were deployed to the Middle East between 2001 and 2009. All ADF personnel deploying to the Middle East between June 2010 and June 2012, and this is referred to as the MEO prospective cohort, and then all regular ADF personnel serving in 2010 who had never deployed to the MEO. And basically we combined these 3 groups up, and that's what formed the ADF Mental Health Prevalence and Wellbeing Study, and from that data we could create prevalence estimates of the entire ADF population. The second study, which I won't be talking about too much today, but Ellie will talk about it in a lot more detail in her presentation, is the Metropolitan Fire Service Health and Wellbeing Study. So for this particular study, participants were drawn from 2 nominal roles, all current serving MFS personnel, which is 830 of them, which we're calling career firefighters, and then all current serving retained MFS personnel, and there's 205 of those, and these are individuals who are mostly on call and regional command positions. So this study used almost exactly the same methodology as the Mental Health Prevalence and Wellbeing Study, which is great because we can compare across populations, and we're also able to establish the prevalence estimates of disorder in this population as well. So this is the first time in Australia that we've ever known the true rate of disorder in these populations, so they're quite important studies. And the third and the most recent program of research is the Transition and Wellbeing Research Program, and Graham provided a bit of an explanation of that there. Basically that looked at the mental, physical and social health of all recently transitioned ADF personnel. So these are people who left regular service between 2010 and 2014. We also looked at a group of ab initio reservists they're people who've always been in the reserves and never been in the regular forces, and it also included there was sort of 3 studies to it. There was a mental health prevalence study. I'll just move on to that next slide. The first study was the mental health and wellbeing transition study. So this is the one that looked at the 24,000 people who'd left the regular service and the reserves. We also looked at a sample of 5,000 current serving personnel as well, and then combined that up with data from about 22,000 people who we surveyed in 2010 and followed up in 2015. The Impact to Combat study was the second component of that, and that followed up on the mental, physical and neurocognitive health and wellbeing of about 1,350 ADF members who participated in the MEO prospective study back in 2010. And this was really aimed to examine the longitudinal trajectory and risk and protective factors for mental, physical and social health in a combat exposed group. So in addition to the mental, physical and social health measures in this particular study, we also had biological and neurocognitive measures as well. And the final study is the Family Wellbeing Study, and this is the one that was led by the Australian Institute of Family Studies. And this looked at the wellbeing of families who were involved in the Transition and Wellbeing Research Program, so mostly transition personnel, and it was looking at the health and wellbeing of those families. I won't go into too much detail here, except to say that the methodology across the mental health prevalence study, the transition study, and also the Metropolitan Fire Service Health and Wellbeing study was pretty similar. We employed a two-phase design. So in the first phase, a self-report questionnaire is administered to as many people in the population as we can contact. And then based on that and certain demographic characteristics, we select out a subpopulation who we interview using the composite World Mental Health Initiative version of the composite International Diagnostic Interview. And that allows us to look at the prevalence of 12-month and lifetime DSM-4 and ICD-10 disorder. And what happens after we collect all that data is we do a robust two-stage weighting process, and that adjusts for any selection biases and attenuates the impacts of low response rates for certain groups. We also have a range of self-report measures that we administer, and these are things that are typically used in deployment screening measures, such as the PCL, the K10, the audit, and the PHQ. And then there's a number of measures in there on pathways to care, information technology use. We look at lifetime trauma and basically a whole range of physical indices as well. So it was very hard actually to reduce this down to key messages, because this is such an enormous amount of research that's gone into this, but I thought I would really just skim the surface and just let you know the sort of main findings that we've found here. And I think it was really important, Susan's comments about the importance of research. So really, in this kind of work, we need to know the extent of the problem before we can do anything about it, and that's really where these studies have come into play. It's really looking at what are the rates of disorder so that we know where we can input resources in order to deal with it. So the first key take-home message is really that the rates of affective and anxiety disorders are higher in current serving ADF personnel compared to members of the Australian community. So this is probably not rocket science to anyone here. It's also not to say that everyone in the military will develop a disorder, because that's certainly not the case. But at a population level, the prevalence of affective and anxieties are higher than those people who have not been in the military. This table here is pulled from the 2010 ADF Mental Health Prevalence and Wellbeing Study, and we compared the rates of disorder, the rates of diagnosable disorder, in this case ICD-10, with the rates of mental disorder in the Australian community, and that Australian community was matched for age and sex and employment status. So what we found here was the most common 12-month disorder type in the ADF was anxiety disorders, followed by affective disorders and then alcohol disorders. Post-traumatic stress disorder was significantly higher in the regular ADF serving population, which is 8.3% compared to the Australian community. And in contrast, in the Australian community, panic attacks were the most common anxiety disorder type, with rates of panic disorder significantly greater than in the Australian community compared to the ADF. Depressive episodes or affective disorders were also higher in the ADF compared to the Australian community, with 6.4% of ADF personnel meeting criteria for depressive disorders in a depressive episode in the past year, compared to the general community rate of 3.1%. And overall, alcohol use was lower in the Defence Force compared to the Australian community. Now, interestingly, when we look at 12-month ICD-10 disorder in the Metropolitan Fire Service and compare it to the ADF in the Australian population, so we have the MFS here in orange and the ADF in blue and the Australian population in yellow, you see that the rates between the Metropolitan Fire Service are actually quite similar to the Australian rates. Similar to the ADF, alcohol disorder rates are much lower in the MFS compared to the Australian community, but in general, they're very similar. The second point I'd like to make is that there is a picture of increasing severity of both mental and physical health symptoms from service to civilian life. So if we look at this figure from the Transition and Wellbeing Research Program, we see higher rates of mental disorder across the board in those people who have transitioned compared to those people who remain in service. So, for example, an estimated 46.4% of the transitioned ADF members, these are recently transitioned ADF members, met criteria for a mental disorder in the previous 12 months. Now, this is compared to 22% of those who remained in service. Again, anxiety disorders were the most common, followed by affective disorders and then alcohol disorders. Oops, sorry. Jumped ahead there. So if we look at the individual 12-month disorder types, although PTSD was the most common disorder type in both the transitioned ADF and the regular ADF, the proportion of people in the transitioned ADF with PTSD was much higher. So 17.7% of those people who transitioned had PTSD in the past 12 months, compared to only 8.3% of those in the regular ADF in 2010. So the same pattern emerged for panic attacks. Interestingly, these are also the two most common disorder types in the MFS, with 5.8% for PTSD in the MFS compared to 5.6% for panic attacks. Phobic disorders were also pretty common in the transitioned ADF in particular, with 11.9% of the transitioned ADF meeting criteria for agoraphobia and 11% meeting criteria for social phobia. So this obviously indicates some level of social impairment in this population. And alcohol disorders were more than double the rates in the transition population compared to those who are in the regular ADF. So what we're seeing is when people leave, their alcohol consumption tends to go back to what it is in the Australian community. The association between transition and poor health outcomes is not limited to mental health symptoms, of course, with transitioned ADF members also reporting significantly more physical health symptoms overall, more service-related injuries, increased lifestyle risk factors, poorer self-perceived health, poorer satisfaction and quality of life, and a greater risk of circulatory conditions, high blood pressure, musculoskeletal or connective tissue conditions, chronic low back pain, nervous system conditions, and hearing loss. So thirdly, there are a number of observable early indicators of emerging disorder that can be used to predict poorer outcome in service members over time. And this is probably one of the most important findings, I believe, to come out of this research. So the first early observable indicator is subsyndromal symptoms. So results from the Transition and Wellbeing research study, for example, indicated that a substantial proportion of both the transitioned ADF and the regular ADF in 2015 reported subsyndromal levels of mental health symptoms. So as an example, between 20 and 50% of the transitioned ADF scored equal to or above the screening cutoff on self-reported measures of anger, psychological distress, PTSD, alcohol consumption, and general anxiety. When we look at the long-term outlook for these individuals, we now know that it is these individuals with subsyndromal symptoms who are likely to be the ones who either maintain those level of symptoms over time or go on to progress having a full disorder. So this slide is from the Transition and Wellbeing Longitudinal report and represents combined K10 and PCL scores for the almost 8,000 participants who completed both the Milhop program of research and the Transition and Wellbeing research program. So not surprisingly, most of the longitudinal cohort reported having no disorder in 2010 while they were still serving, which is the top column. Approximately a third were subsyndromal in 2010, which is the second column, and just under 10% had a probable disorder in 2010. When we break it down, though, according to how those people were in 2015, we see that among those people with no disorder in 2010, most people still have no disorder, right? So that's the green on the top column. A small proportion have developed subsyndromal disorder and a slightly smaller proportion have developed probable disorder. So even if you have no symptoms back in 2015, there's still a likelihood that you'll go on to develop symptoms 5 years later. Interestingly, however, if you look at those who were subsyndromal in 2010, which is the second column, and those who had a probable disorder in 2010, which is the final column, you see a much larger proportion of those symptoms either maintain their symptoms, so maintain their subsyndromal symptoms, which is the orange component, or go on to develop a full disorder. So what you're seeing here is a definite risk factor for later progression of symptoms. And I'm sure that's not, everyone will know that, but it's also a point, it's a really important point for early intervention. We can pick up these things early and we know we can start to really intervene. Other early indicators of emerging disorder that have emerged are problematic anger and cumulative trauma and deployment exposure. So the next three slides look at factors that predict disorder emergence, factors that predict disorder maintenance, and factors that predict progression, and then factors that predict disorder emergence. So the first one here is looking at those people who have no disorder in 2010, which is on the left in green, and it's looking at those people who've either progressed to have subsyndromal disorder in 2015 or full disorder. And what we see here is that anger in 2010, as well as the number of deployment traumas and the number of lifetime traumas, are the two factors that are likely to indicate that someone's going to develop subsyndromal symptoms or develop a full disorder. Interestingly, when we look at those people who are subsyndromal in 2010, we see exactly the same thing. So if you're angry in 2010 and you have subsyndromal symptoms, you're more likely to either maintain those symptoms in 2015 or go on to progress to having a full disorder. And the same thing again for those people who are actually having a probable disorder in 2010. Anger, number of traumas, and number of deployment exposures, and number of lifetime traumas are the things that are most likely to predict that that person will maintain those disorders over time. The final thing I'll talk about today, and I'm desperately running out of time, so I'll be quick, is that there are certain service members who are at greater risk of poor mental and physical health outcomes than others. So consistent with previous research, we've shown that early service leavers are at a big risk. So if you've been in service for less than 4 years, then you're at a big risk of having mental health problems when you leave the Defence Force. For PTSD in particular, it's those people who serve between 4 years and 7.9 years who are at the greater risk of developing PTSD upon transition. There are also a number of transition service and demographic risk factors. Years since transition is another one. So in the first year following transition, most people do okay. It's around that 12-month mark and around the 3-year mark that things start to go badly. Obviously, if you've been medically discharged, you're more likely to do poorer following transition. If you're a DVA client, you're more likely to do poorer following transition. And this is not because DVA is traumatising people, but it is because if you have a condition, then you're more likely to seek services from DVA. So it's, of course, likely that you'll have more likely to have a symptom. Ex-serving, so the more removed you are from defence, the more likely you are to have a mental health condition following transition. Lower rank and army also have the highest rates of mental disorders in this population. And in terms of sex, nothing overly consistent. Males are more likely than females to report suicide attempts and alcohol disorders. Also females compared to males are more likely to report anxiety, and that's pretty consistent with the general Australian literature as well. Now, while the rates of initial engagement and uptake of mental health services was reasonably high, there was an under-engagement with evidence-based care. This is really important. What we're seeing is basically there's a willingness to seek services, but once they get into services, they're not always receiving the services that they need or the services that are helpful to them. We know that about 30% of people who receive evidence, only 30% of people who receive evidence-based care, actually their symptoms resolve. There's a high proportion of people who receive evidence-based care where their symptoms don't resolve. So there's a definite gap here for other sort of treatment adjuncts and interventions. And I know that there's many, many people in the audience here who are promoting things along those lines. So hopefully we can have some discussion about those. And the main conclusions really are that mental health in the Defence Force and the emergency services is it's a transition really, and it goes right from when they first join throughout their whole military service and into transition when they leave. When they're in the service, their symptoms can go up and down. So what's really important as we start to monitor these symptoms at an individual level. Also, if we're wanting to get an idea of the population as a whole and the mental health difficulties in that population, we also need to look at those people who leave, okay? Because if people aren't doing well, they're going to leave. So if we only look at the population at hand and we're trying to estimate sort of rates of disorder on that particular serving population, we're going to have an underestimate. So it's really important to look at those people who leave it as well. I know there's not a lot of research in that space. It's actually really difficult to track people once they leave the services. And we did in fact try and do that with the Metropolitan Fire Service study, but it's just impossible to track people down. So I think that's a real gap with the literature here that we should be focusing on. Probably most importantly is that emerging psychological distress is a significant driver of an individual's decision to leave the service, and it's also a significant risk factor for later disorder. So it's all about early intervention. If we get in early with these individuals, then we can prevent the sort of long-term prognosis. And of course, there are a number of risk factors which we now clearly know impact on the rates of disorder over time, and so we need to start looking at targeting those as well. Thank you.
A little bit about Dr. Ellie Lawrence Wood. Dr. Ellie Lawrence Wood is a Senior Research Fellow at the Centre for Traumatic Stress Studies, University of Adelaide. Most recently, she was lead investigator on the impact of the combat study component of the Transition and Wellbeing Research Program. She's co-authored over 40 peer-reviewed published journals and articles.
I'm going to be talking specifically about occupational exposures in first responder and military populations. Particularly, we know in military and first responder occupations there are occupational standards that require high levels of physical and mental health in order for people to perform their duties. There's a range of selection and training processes, leadership, support programs that all help to optimise performance and support people. But we also know in these occupations there's repeated and regular trauma and stress exposure, and it's a hazard of the job. We know that mental and physical and cognitive health can be impacted by a range of things in the immediate and the longer term. There's lots of research on this, so psychological trauma, injuries, stress, and environmental exposures and toxins. And these are all things that are ubiquitous to not only deployed environments in the military context, but also first responder occupations. So in terms of how much and what type of exposures do we see in these occupations? What's the association between these and mental health in particular? When do symptoms emerge? And potentially what processes underlie the association between exposures and the emergence of mental health outcomes? So I'm going to talk about findings from two of our studies that Miranda's already kindly introduced. So the first is the MFS Health and Wellbeing study, and I'm going to talk about the mental health outcomes in relation to the workplace exposures in this population, and then also the MEO Prospective and Impact of Combat study, which was a prospective longitudinal design, which Miranda's explained, where we went out to a cohort who were deploying, before they deployed, when they came back, and then we followed them up about 3 to 4 years after that index deployment. And so hopefully this will kind of provide an overview of the impacts of occupational exposures. For the MEO Impact of Combat study, we had a range of study components in addition to a survey which was almost identical to the one that was administered to the MFS. We also had subgroups who received physical testing, subgroups within them who received neurocognitive assessments, and we also had a small subgroup who were exposed to blast injury who received an MRI at the third wave. And I'm going to talk about 3 of those. I won't be talking about our MRI data today. So I've condensed this down. In terms of talking about occupational exposures, it's really important to think about the similarities across populations when we're thinking about workplaces where stress and exposure is high. So in terms of the samples for these two groups, they're actually quite similar in that younger to middle-aged males made up the bulk of the populations, relatively high levels of exposure in the course of their occupations, and the majority had a reasonable length of service, so they had experienced quite a lot of exposures in the course of their service. So what type of exposures and how much? So first of all, we have lifetime trauma exposure here in the MFS, and what you see is, in general, they have relatively high levels of lifetime trauma exposure. Most of this is captured in the types of things they do in the course of their occupation. So things like seeing someone badly injured or killed is experienced by a very high proportion of that population. Trauma exposure in the ADF looks very similar. So again, we see a relatively high load of trauma in these groups, and it's mostly clustered around those types of experiences that relate to their occupation. So in this case, combat exposure, peacekeeping, and seeing dead and injured bodies. Workplace exposures, in particular in relation to their occupation, we see very high levels in the MFS. So for example, 95% of this population have witnessed a death in the course of their work. In the ADF sample, these are exposures on this index deployment that we followed up. Again, you see a very high load of exposure with 40 to 50% reporting being in danger of being injured or killed, seeing, handling dead bodies, and coming under fire. So basically we have a lot of exposures in these occupations, but very healthy populations. But we know that exposures can be associated with mental health outcomes in particular. So, in our MFS sample, the majority of the population, as Miranda showed with her slides, are doing really, really well. They look pretty much like the general community. Very few symptoms, despite very significant levels of exposure. However, when you look at the current PTSD symptoms, we do find an association between different types of exposure and the level of these symptoms. And when we model a whole range of different predictors, the exposures always come out as the most important predictors. So the cumulative number of workplace exposures is associated with increases in PTSD symptoms. Specific workplace exposure types as well, and this is actually quite an interesting one for us in that it's not necessarily things like witnessing deaths, which people are trained in these occupations to expect, but things like being injured or call-outs to mental health or to situations where mental health was a concern were the things that were most distressing to these people. So I think it's important to think about the types of trauma. Lifetime trauma load adds to this. So this cumulative load model is really important in relation to effects on symptoms. And then we also measured occupational stresses in this population, and they also contributed to levels of psychological distress. In our deployed sample, pretty much the same thing, just presented a slightly different way. So basically, the amount of traumas and individual experiences on their deployment is associated with the amount of post-traumatic stress symptoms that they report at post-deployment. But this relationship is stronger for those people who go into that deployment with a higher traumatic load before they go. So again, it's this cumulative load model that's really important. And so I guess the next question is, when do these symptoms emerge, particularly when we're thinking about early intervention? So the lovely thing about having 3 waves of data collection on our combat cohort enabled us to really look at this. And what you can see is an extremely healthy population of people. However, there's a progressive recruitment of generally subsyndromal symptoms with the passage of time. And by time 3, so that's 3 to 4 years after that deployment, we found around 1 in 4 were screening above the screening cutoff on the PCL, so sub-threshold symptoms at least by that time point. And what predicts it? It's probably not rocket science. We find this over and over again. It's the level of trauma they went into that deployment with and the number of exposures they experienced on that deployment. We put everything into these models, and these are the 2 things that come out time and time again as the most important factors. So one of the things that's really interesting for us and that this study has allowed us to do is to think about the processes underlying the association between these types of exposures and the emergence of early symptoms. And I apologise because I'm going to do this very, very high level. But basically, when people are exposed to stress or trauma or injury or illness, the body mounts a response, a physiological response, and we can measure elements of that response. And in this study, we have 2 things I'm going to present. First of all is the immune response, so inflammatory markers. When people are stressed, their inflammatory processes kick in, and you can measure those in people's blood. And then also brain function, so people's resting brain states. I was in the workshop this morning about art therapy, really interesting in terms of talking about resting brain states. So I am going to present, first of all, our inflammatory markers. What we did is in this sample, we divided the sample according to whether they were in that 25% who were screening above the cutoff at wave 3 versus everyone else. And what we saw is a difference in their inflammatory profile at baseline. And basically, these people were the people who went on to be symptomatic were also those people who had a higher trauma load at baseline. This was a bit perplexing to us because we would have expected to see an elevated inflammatory response in our people who went on to be symptomatic. However, we saw the opposite. So they had a lower inflammatory response at baseline, and we immediately thought of cortisol. So when people are stressed, cortisol elevates. In people who are chronically stressed, you actually see a blunted cortisol response. So this potentially is pointing to something like that. And then the interesting thing is the healthy subgroups start to look more similar in their inflammatory profile by our 3rd wave follow-up, which begs the question of will they have emerging symptoms into the future? Resting brain function, so this is alpha waves, and basically the higher your alpha waves are, the more chill you are. It's your kind of chill, relaxed zone. Very, very important to have that. The lower your alpha waves are, the more vigilant you are. And so we see a strikingly similar pattern where at baseline, our symptomatic subgroup looked different. They had lower alpha waves. And we also see our healthy subgroup starting to look more like our symptomatic subgroup by wave 3. So, I guess the most important point is the level of exposures in these occupations is really, really high, and all different types of events and exposures have the potential to have an impact on a range of different outcomes. And it's this cumulative load of exposure that's most important. Health impacts are multidimensional, so it's not just your mental health, it's the physiological systems that underpin this. Cognitive health, we've got a whole lot of data on working memory, emotion regulation, and we see changes in all of these things. So in an exceptionally healthy population, this slow, progressive emergence of symptoms across multiple domains kind of gives us a point of intervention or risk mitigation. Basically, subtle shifts are detectable well before you actually see any kind of observable detrimental effects. So in terms of a focus, multidimensional. So I kind of think about it as like a high-performance vehicle. You don't just look at this bit or this bit. You need to look at it as a whole. And so people are the same. You need to think about this as a whole system. So you don't just focus on physical, not just mental. You should be focusing on these holistically and identifying and monitoring early changes. For example, small shifts in mental distress, as Miranda was talking about, or someone's perhaps finding it difficult to sleep, difficult to relax. Those could be like, you know, your oil light coming on in your car, a signal to have a service, to do something. And there are things that we can do. So things like exercise and diet can have an impact on the immune system. They can have an impact on your brain function, on your mental health symptoms. Meditation's one that's quite interesting. The art therapy, it looks like that potentially could tap into some of this alpha wave stuff, so improving your alpha waves. And there's things like brain training. So I guess that's kind of the take-home message in thinking about occupations where there are high levels of exposure. That's it's a part of the job. So how do you risk mitigate and improve, optimise performance and stop the progression of symptoms before they become problematic?
And our third speaker is Dr. Galina Garagonova. Dr. Garagonova is Executive Manager running the Longitudinal and Life Course program at the Australian Institute of Family Studies. Galina is a recognised expert on longitudinal studies and is responsible for managing significant national studies. Presenting on the Australian context, combat, transition, first responders and families. Please welcome Miranda, Ellie and Galina to the stage.
Hello everyone. I'll take you on a very different journey, and I'm not going to talk about the ADF members or members who were participating in the first responders, but I'll talk about their families and what does it mean for families to have a family member who is in this risky profession. As Miranda mentioned, the study I'm going to talk about today, it's a family well-being study, and this study was part of the Transition Wellbeing Research Program, and it was commissioned by the Department of Defense and Department of Veteran Affairs. And the idea was that while it has recognized that families are important, there is no data in Australia that actually collects very detailed information about family members and their experiences. The other probably thing that I really would like to mention about this study, this is really, really unique study from the perspective that this data is collected not only from the family members, very similar data is collected also from the ADF members. So it allows you the comparisons. People were asked, all family members were asked exactly the same questions about what they think about their relationships, about their mental health, how they think the mental health of their family members, whether it's good or bad. So this is a very rich data that could answer quite a lot of questions. The other thing to mention that this study was divided in two parts, and the first part was a big quantitative study, and the other part was qualitative study. And the qualitative study was in particular interested in understanding what is the successful transition is. I'm not going to talk about it today in this presentation, but if you've got questions, please feel free to ask. I'm not going to spend a lot of time about why it's important to study ADF families or any families. I just want to probably emphasize a big gap in the literature. So it has been recognized that families are important. They're important for the ADF members, to support them, to make their transition easy, to support them while they're on deployment. But there is not enough information, not enough research and understanding of what it means for families themselves, how it affects their mental health and well-being, their financial situation. And I think the other really, really big gap in the research, it's a lot of time when we talk about the families and their roles, we talk about families when ADF members are deployed, or we talk about the spouses and partners, and to some extent about young children. There is not much information about any other family members, adult children, parents, siblings. So this study was able actually to shed light on all different family members. Again, I'm not going to talk much about the sort of foundations for this study, just to say that when ADF members are in the military, family experience very, very different compared to when ADF member is coming back home when it's transitioning. So when ADF member serving, family members experiences a very, very high level of residential mobility. There is constant separation and unification. So there is a lot of differences in employment opportunities for the family members, especially for spouses and partners. And there is a possible financial burden. When we talk about the transition, it's completely different experience, because when ADF members come back to the family, they need to renegotiate their roles and responsibilities within families. If families got kids need to understand completely different environment that everyone is going to live. There is a lot of changes in terms of the social capital and social network that needs to be negotiated. And of course, if ADF members who are transitioning, they're coming home with special health needs, it's also readjustment among the whole family. So the study, the other thing to mention, it's actually very, very different methodology compared to what Miranda and Ellie mentioned, because it's not possible to actually recruit family members to the studies. Family members to the studies can be recruited only via ADF members, and family members were recruited when ADF members were filling in their surveys, they were asked to nominate their family members. And actually, the nomination rate was quite low. It was only 20% of ADF members who wanted their families to participate. However, if we talk about family members themselves, they were really, really eager to participate, and participation rate was above 55%, which is actually unbelievable for the studies of this kind. And you can see that regardless of the very good participation rate but bad nomination rate, we ended up with sample size just under 1,500, and you can see that we had 962 spouses and partners who participated in the study, 102 adult children, 275 parents, and when you see the numbers for children, it's not the children who participated, it's children who were 2 to 17 years old. It's actually spouses and partners as well as ADF members. They reported on children's well-being, mental health, and also their parenting practices. And they were reporting, so if the family had a number of children, they will be reporting on the same child. As you can see, we had ex-serving as well as current serving, and we had more current serving members. There was a range number of outcomes that have been examined, and it was online survey of about 40 minutes. We've examined mental health and risk-taking, parenting practices, physical health and quality of life, child behavior problems, those who were from age 2 to 17, couple relationships, and when we talk about the couple relationship, we examined abuse in the relationships, quality of relationships, and whether they were happy or not in these relationships. I would like to focus a little bit more on mental health indicators, because it's also quite different from what Miranda and Ellie talked, because in their studies they used diagnostic tools. Here it was all self-reported measures. And this is a big difference. And just to give you a very, very brief overview, actually when we look at spouse and partners, we see very positive picture with overall rates being very, very similar to the Australian population. And if you can see that majority have been employed, 60% were employed full-time, 40% were employed part-time, there was much higher residential mobility, many more ADF families were changing their places of residence, and also kids, they were likely to change schools up to 5-6 schools within 4 or 5 years period. And couple relationships, if you look, it's actually quite interesting, because if you look at the couple relationships, the national statistics using the ABS data, the abusive relationships been reported by 7% within the national statistics. Among the currently serving ADF families, it's only 3%. It's significantly lower. However, if we look at the ex-serving families, the rates are pretty similar to what we've got in the general population in Australia. Regardless of that, we've got quite a positive picture. Some subgroups had actually poor outcomes. So, for example, low rates of relationship satisfaction and happiness and good quality relationships were among families who had the family member who was reporting on the relationship had psychological distress and poor physical health, or if ADF member had a psychological distress and poor physical health and also had drinking problem. Again, this is not something very new and surprising, because this is aligns with the general literature, general Australian literature. And also it was interesting to note that higher rates of relationship happiness and good quality relationships were among those who were families with longer lengths in ADF service, who actually were of higher rank, families who didn't have children, and families whose partners who had higher education certificate or diploma compared to the actually higher education, university degree. If we think about the mental health, again, we can see very positive picture with overall rates being similar to the general Australian population, and there were no difference. However, if we go and look deeper, we can see that again, subgroups, they've got worse outcomes. So for example, if we look at the spouses and partners who were also ADF members, their mental health is much worse, so they've got higher rates of psychological distress, higher rates of PTSD, and they've got less warm parenting. And if we talk about the compare spouses and partners of recently transitioned ADF members, their outcomes is also worse than those outcomes of partners and spouses of currently serving ADF members. I think the most interesting finding that probably rarely talked about is that actually if we look at adult children, they experience the worst outcomes compared with anyone else. And these findings, interestingly enough, are very similar to the Vietnam Veterans Family Study. We've looked at the adult children 40 years after the Vietnam War and compared to the Vietnam era personnel adult children, and we had very, very similar results. That adult children are actually on multiple outcomes, they've got poor outcomes. Even so, if we look at the overall picture, looks pretty good, but if you look across all different family members, you can see that adult children, they've got worst outcomes compared with spouses, partners, or parents. So this is about the high psychological distress, this is the suicidality in the past 12 months. And interestingly enough, again, not a surprise that young children, they also got poor outcomes. So the mental health of young children was measured with the Strengths and Difficulty Questionnaire. This is a widely used diagnostic, it's not a diagnostic tool, but this is a symptomatic tool where they look at the emotional symptoms, hyperactivity problems, peer problems, and conduct problems, and they generate the total behavioral problem scale. And this scale is actually, they've got a threshold, and this threshold sort of identifies mental health problems. And we can see that children of currently, it's again, the difference between currently serving kids from currently serving families and transition family, we've got a very different picture. Those children, young children who are in a currently serving families, they've got much worse outcomes compared with those who transition from the military families. In general, and just to conclude that in general, you can see that military families members didn't show higher rates of mental health problems than in the general Australian community, which is really good and quite sort of pleasing result. Nevertheless, some subgroups seemed more vulnerable than the others. And as I said, adult children, they were more vulnerable. Young children, especially in families of currently serving personnel, spouses, partners who also served in the ADF force, and spouses, partners whose servicemen have recently transitioned to the civilian life. Just probably to think about, I will probably touch base, I'm not going to talk about this one, but one thing that I would like to mention based on the qualitative study, during the qualitative studies, a lot of families were asked about what is a successful transition, and everyone said that successful transition is when families are engaged in the transition, which not many families experience because they are not aware of the transition seminars, they are not invited, and if it's there, it's mainly for the spouses and partners. So, and on this note, I would like to finish and thank you.
I'd just like to thank Miranda, Ellie and Galina. A really comprehensive insight into combat, transition, first responders and families, the Australian context.